So we did a study looking at more than 100,000 patients, 148,000 patients to be precise, in association, in collaboration with Foundation Medicine. And what we did was to look for the presence of BRCA1 and BRCA2 alterations in these genes in these patients. As we know, taking a step back, what is the role of BRCA1 and BRCA2 gene alterations? We know, based on studies done in ovarian cancer and breast cancer, that patients harboring these mutations, either in germline or in the tumor, they may respond to treatment with PARP inhibitors because they cannot repair, they have the deficiency in the double-strand DNA break. So if you use PARP1 inhibitor in these patients, which lead to single-strand DNA breaks, and they do not have the capability, or tumors do not have the capability of repairing the double-strand breaks, this leads to something known as synthetic lethality, and these cancer cells die. Based on this principle, multiple PARP inhibitors are now approved for treatment of ovarian cancer and also in breast cancer patients. Now, what is the application of these drugs, or potential application of these drugs in other cancers? That was the main question we asked. What is the prevalence of BRCA1 and 2 alterations in other cancers? And surprisingly, or maybe not so surprisingly, we found that multiple other cancer types, many of the common cancer types, such as prostate cancer, stomach cancer, pancreatic cancer, bladder cancer, or urothelial cancer, they also were harboring these mutations. So should we extrapolate these findings to efficacy of PARP inhibitors in these patient population? Do we assume that these PARP inhibitors will be efficacious just because they are harboring BRCA1 and 2 alterations? And answer is maybe not. So should we assume that PARP inhibitors are going to be effective in other cancers also? Answer is maybe not. Why? Because we also know that PARP inhibitors are a lot more likely to work if there is a certain level of genome-wide loss of heterozygosity, or LOH. And that is predicted by the homozygosity or biallelic nature of these BRCA1 and 2 alterations. For example, in our study, patients who were harboring BRCA1 or 2 alterations on only one allele, and other allele was completely normal, their genome-wide loss of heterozygosity score was as much as those without these alterations. On the other hand, patients who were harboring BRCA1 and 2 alterations in both alleles, whether similar mutations or different mutations, which is homozygosity or biallelic loss, their genome-wide loss of heterozygosity was much higher, and they were more likely to respond. Based on the ovarian cancer trials, we know they are more likely to respond to PARP inhibitors. So the question arises, what should we do with patients in other cancer types who may not have genome-wide loss of heterozygosity as prevalent as we see with ovarian and breast cancer? Answer is very simple. We need to look for zygosity status. So simple presence or mere presence of BRCA1 and 2 alteration may not be sufficient in these patients. Patients with pancreatic, bladder cancers, prostate cancer. In those patients, I think it's very important to also look for the homozygosity or biallelic loss of BRCA1 and 2 alteration, which will likely extrapolate to increased genome-wide LOH and increased likelihood of their response to PARP inhibitors.
And for these others who do have the response markers, is there room, you think, for N of 1 trials for getting real personalized medicine, for saying we didn't expect to see this mutation in this tumor, but you've got it and we've got a treatment? See if anyone is willing and ready to participate and embrace this possible personalized medicine approach.
This is personalized medicine. We are first identifying the presence of these alterations either in germline or in the tumor. Then we are determining the zygosity status of these alterations. And then we are offering them treatment with PARP inhibitors. And that's a perfect example of personalized medicine. And good news is for our patients is that these testings are available on a commercial basis. We can order these testings in the context of genetic counseling. So I do want to mention that presence of a genetic counselor in the team, multidisciplinary team, which is taking care of these patients, is extremely important.
And then for these other patients, the genetic counselor, I suppose, must also play the role of trying to communicate that it's not that they've got a worse mutation or a better mutation, but that it's just approaching what can be done next. What is the best case scenario? What is the best care for these patients?
So genetic counselors play an important role in my view, very important role, because many of these mutations may seem like mutation, but they may not be pathogenic. So when you do these panel testings and you see results in these genes, it's not only BRCA1 and BRCA2, there are a lot of non-canonical pathways or genes which may be affected and may or may not be associated with what we call as homologous recombination defect. Who is going to tell those patients? I think genetic counselors play a big role here. Going beyond the patients, if these patients are harboring these mutations in the germline, it is the genetic counselor who is going to counsel the patient and patient's family about the implications of those mutations and may want to recommend further testings like screening of family members.
Any plans for using a similar technique to try and assess patients for any other mutations which are similarly linked to disease progression, BRAF, MEK mutations that may not have the same awareness in the general populace as BRCA mutations, but are still linked to disease onset in different organs?
This is $1 million question. When we do comprehensive genomic profiling of tumors in our patients with different kind of cancers, we often see many different types of genomic aberrations. What is the implication of that in the treatment of these patients? We know in many cancers, such as in lung cancer, mutations in EGFR or ALK, they predict response to certain therapies which are approved based on randomized trials utilizing these drugs in these patients with specific mutations. But in my view, based on the current data, most of the patients who are found to have these genomic aberrations in comprehensive genomic profiling, we do not have targeted therapies available. It doesn't mean we are not going to have targeted therapies available for them, but at this point of time, for most of the patients, we do not. But I think this is just a start. And as the field moves forward, newer targets are being identified. I'm sure newer drugs will be approved in the near future and will improve survival outcomes in our patients.